Thanks. Thank you very much. Thank you, Muhammad. It's always a pleasure to be with you. I'm just going to, for the sake of time, go with my cases. I've got two or three cases which are a combination of medical and surgical retina. This was a 70-year-old, usual diabetic, as Ahmed was saying. Most of our patients, unfortunately, are fully controlled. She came in to see us with decreased vision in both eyes. She's pseudophakic, and she was not comfortable with the idea of having monthly injection. After trying to convince her, she got two anti-VEGF. We used Eylea in this case, and the vision did, you can see the edema in both eyes, more so in the left eye. With the anti-VEGF Eylea injection, aflibercept, she improved in the right eye, but she did not show major improvement in the left eye. And at that stage, I discussed with her, if she is not willing to come monthly, the possibility of steroid implant, and we decided to go ahead and use DEX implant in both eyes. You can also see, looking at the OCTs in both eyes, the usual OCT biomarkers of inflammation in the form of subretinal fluid, the hyperrefractile dots, and the cystoid changes. The right eye actually did very well, and the vision did improve, but the left eye, this is just a technical point, as Ahmed was saying. When you're injecting dexamethasone, you want to, just like when you insert the trocars during the vitrectomy, you stay at an angle first, and that's very important. And that is different from Elevine, as you'll see in a second. And I routinely inspect these patients after injection. So as I said, her right eye did show an improvement, was very stable, but the left eye recurred after 4 months. Her IOP, which I usually check in the second month or after, then in the middle of the second month, remained very stable. And she was still not comfortable with the concept of using anti-VEGF, monthly injections. We decided that we're going for DEX, for the second DEX to the left eye, but for a reason, she traveled abroad, I think for knee surgeries, and she received the Elevine implant. She came in to see me after almost a year after the Elevine, and she looked actually pretty well. The macular edema, her right eye remains stable, but the left eye, this is her left eye, which has shown a definite improvement with improvement of the visual acuity. And at that stage, I consulted her on using combination therapy and injecting her with anti-VEGF twice, and she's done well. She came last week to see me. It was very interesting because I had her almost 3-year pictures, and she looked pretty well, actually. And that gives us an idea of the stability of the Elevine implant in these inflammatory cases, whereby you can see the improvement both anatomically and functionally. And again, just a technical point here, when you're injecting Elevine, you can see that you want to be perpendicular, whereas in DEX, you come at an angle, and I think that's probably an important technical point. Things I want to, the take-home message from this is that I think we're not switching early, and I think switching early is very important in these patients. If you keep on injecting anti-VEGF, I know in this patient this was a compliance issue, but I've seen people who've continued injecting anti-VEGF for 6 or 12 or sometimes more than that. I think you ultimately get thinning of the retina, but the vision is lost. So I think switching early is important for the functional improvement that we want to get. Combination therapy is important. I was really impressed with the results that Dr. Ahmed presented, because in my experience and internationally, the Elevine implant would require at least 6 to 8 weeks to show an improvement, and sometimes during the course you might have to use top-up either in the form of DEX or even anti-VEGF. This is what I'm saying here. The second case, I'm just going to move into the second case, was a 42-year-old female, nice, educated. She's pregnant in her second trimester. This was a very precious pregnancy. She came in with blurred vision in her left eye for a few weeks. She's non-hypertensive, under control. Her visual acuity was 20/20, 2100 in the other eye, with very mild hyperopic astigmatism, normal IOP, normal anterior segment. Her fundus examination, including the optos, looked initially pretty okay. Her OCT showed classically the macular edema with classic subretinal fluid and cystoid changes. When I went back to look into her carefully into her left fundus exam, I could see like an old vein occlusion, which is probably resulted in this. After consulting with the patient because of her pregnancy, I was worried in using anti-VEGF. We agreed to use dexamethasone, which is done pretty well. And it's my experience, and I don't know about what the panelists think, but these patients, the vein occlusion patients, respond very well to the steroid implant. Of course, we agreed that after delivery, she might go back and use anti-VEGF. I think I just wanted to stress the importance of the OCT biomarkers. You want to look at them. We're considering now naive patients sometimes. You want to look at these serous retinal detachments, the presence of hyperreflective dots and cystoid changes, which are all suggestive of the fact that these patients might not be good responders to anti-VEGF. And all the studies, whether it's the real life studies or the randomized trials, have shown that you have approximately 1/3 of patients who will not respond well to your anti-VEGF, and I think you should keep steroids at the back of your mind, and I think switching early is a key. I'll take you into a third case, which is more of a surgical case. This was a 50-year-old gentleman who comes to see me, referred after having 8 anti-VEGF injections with not major improvement of his macular edema, and he's also had some evidence of PDR. So we agreed that we're going to treat this with surgery, and I think surgery is an option that should be kept at the back of your mind. And we need to understand that some patients are tractional, so no matter how much injections you give them, you ultimately need to go for surgery. I'll show you quickly the procedure. I decided to keep the lens, and I'm I routinely in these patients, this was just a cord vitrectomy. You can see the tractional component on the macula. I routinely use triamcinolone. I know Dr. Carlos does not like to use them, but I find them very useful, specifically in diabetics. They show you the vitreous. There's a lot of vitreous cases. You can see here I'm trying to induce PVD. You want to be slow. You want to take your time. You allow some hydration. And then slowly you can see a little bit of bleeding that is usually managed well with increasing the intraocular pressure, and ultimately you will do the PVD. And then after that, I leave a little bit of this triamcinolone as an anti-inflammatory, so it truly helps, especially in these diabetics. They always have these vitreous cases. A little bit of endolaser also, and then I do air fluid exchange, and I leave them with air. Just few tips, practical tips for inducing PVD. We know that PVD in diabetics is somewhat a difficulty. I think visualization is very important when you're inducing PVD. You want to make sure you're seeing everything very carefully. You would like to start at the edge of the disc and you move up. And this is one of the mistakes that we see with some of the junior staff or the new-coming fellows. They tend to pull towards the sclerotomy. You want to move up. And you would like to be patient, give some time for hydration, and then you will see that it will come slowly. And I think everybody is going into smaller gauge, and it definitely going into smaller gauge means that you're going to get closer to the retina, but I think you would like to be careful because smaller gauge does not mean smaller problem. And if there is a retinal detachment, in these cases, sometimes you have either combined tractional, retinogenous, or tractional, you always want to start facing the attached retina. So going back to the patient, she initially showed reasonable improvement. Within 2 months, his vision improved, still had some evidence of macular edema. And at that stage, because he's phakic, we decided that we're going to use anti-VEGF. I used, again, aflibercept. And after 2 injections, the macular edema kept on fluctuating. And then I told him that, you've got a little bit of cataract. There's a good chance that we're going for surgery. So we decided that we're going to Ozurdex after discussing the possibility of surgery. The IEP remained normal, and he responded actually very well, and his vision is improved. Now, one of the points that I wanted to raise is that these patients, after vitrectomy, the half-life of anti-VEGF is much reduced, so the effect is going to wear much faster, and thereafter, the concept of long-acting depot medications like Ozurdex is definitely important. And this brings us to this point of the mean retinal thickness amplitude, which is an interesting point that has been brought up, which I think Dr. Carlos in his first and also Dr. Ahmed alluded into it. You see, when you treat these patients, the fluctuation that happens in retinal thickness is somehow somewhat damaging each time. The retina, the macula, like a sponge, swells and decompresses. You get some damage, and I think the mean changes that you see with the Illivan implant is definitely less. And in a study that showed that the changes prior to the insertion of the implant were around 230 micron, while with the implant is 96 micron. So we would like to have a stable control, which definitely is achievable with the Illivan implant. I think that takes me to the end. This is nobody is in the corniche, like and hopefully once we get this COVID-19 problem over, we will go back and enjoy it. And I hope everybody stays safe and inshallah we will get over this. Thank you very much.
Thank you very much, Dr. Saad. It's for this very interesting cases.